Welcome to my workshop. Just a note before I start, I didn't begin recording the actual in-person session until around slide 4, so I am recording myself going through the first few slides after the fact, and then I'm going to stitch this recording to the actual in-person recording. So in a few minutes, the audio will change and the video might change too, and just know that's because that's the point when I remembered to start recording the actual in-person session. So the title of my workshop is Tailoring Medical Rides to Improve Public Health, Addressing the Needs of Diverse Riders. And the agenda is, first I'm going to introduce my topic and research problem, which will take about 25 minutes. And then I'll spend 10 minutes going over my research approach and study design, and then the last 10 minutes will be for discussion and feedback. So if you recall, the title of the talk is Tailoring Medical Rides to Improve Public Health. So let's start out by defining medical rides. A medical ride is any transportation used to reach healthcare services. But that's really broad, and I want to get a lot more specific here at the beginning and talk about a certain kind of medical ride or medical transportation that I'm interested in, which is called non-emergency medical transportation, or NEMT. And NEMT is the name given to our federally funded program that provides medical transportation specifically for Medicaid beneficiaries. And Medicaid beneficiaries are low-income individuals. So Medicaid is our federally funded program that provides health insurance for low-income individuals. So why am I interested in non-emergency medical transportation and medical transportation for Medicaid beneficiaries? Well, it all goes back to my experience as a planning practitioner at an MPO. I was the lone planner on our team tasked with overseeing and managing the network of NEMT providers in our region. And I learned a lot more about NEMT doing this research than I did actually working as a practitioner. But I did still know a little bit back then, and I just noticed a lot of problems with the way NEMT was being delivered. And so that gave me motivation to look at things a little bit more closely as a doctoral student. And those problems with NEMT that I observed as a practitioner are the same problems that I'll be trying to address in this workshop. And then I'm also generally interested in the links between transportation and health. So medical transportation is really the best of both worlds. So the research context. So NEMT is kind of that pulls from different domains of research, the first of which is transportation planning. There's a big subfield in transportation that looks at accessibility and how we measure accessibility. And then a small piece of that looks at access to healthcare. So that's where NEMT fits in to transportation. And then there's public health, a really growing body of research that looks at health disparities. And some of that looks at health disparities experienced by Medicaid recipients. So that's how we fit into public health. And then there's also the policy and governance world. Lots of scholarship on Medicaid policy and transportation policy, and NEMT is a combination of those as well. So now I'm going to get into the history a little bit. I think learning this information was really helpful for me in trying to learn what NEMT is. So I hope it's helpful for you all too. So NEMT can be traced back to 1965 when Medicaid was established by Lyndon B. Johnson, which is a fun local connection. But there was this kind of vague clause in the Medicaid legislation that said Medicaid services must be provided in a manner consistent with the needs of the recipient. And so Medicaid is a really, it's federal legislation. So the federal government kind of gives this guidance and funding to the states, and it's on the states to interpret the guidance and implement the program on a state-by-state basis, given the guidance. So states kind of saw this vague clause, and some of them started to implement medical transportation, but others didn't really flag this and didn't provide transportation until I think 1974. There was a class action lawsuit called Smith versus Bowell that also happened here in Central Texas, oddly enough. The plaintiff was a person with cerebral palsy who was unable to transport themselves to their doctor's appointments, and they were on Medicaid. And so they sued the state of Texas for not providing access to Medicaid service. And they won the lawsuit. And so this case kind of required that all states offer NEMT. In the 80s, we have a wave of privatization that sweeps the country, and it impacts all sectors of the American economy, including healthcare. So prior to the 1980s, we have a fee-for-service model in healthcare where the patient will pay the exact cost of all the services that were rendered unto them during their doctor's appointment. But after this wave of privatization, we see the emergence of health insurance companies. And that's why today we pay, most of us, the monthly premium that goes into a big pot of money and then is used for health insurance payouts. So that kind of changed the way Medicaid worked, but it also changed the way medical transportation under Medicaid worked. So prior to the 80s, NEMT was provided by public transit agencies, but after the 80s, we see the emergence of NEMT as a business that anybody can start up. And so there are kind of public NEMT providers and private NEMT providers, and they don't really talk to each other. And that's still the case. And a little side note is if you search NEMT on YouTube today, all the videos are about how to create your own NEMT startup and how to make money by providing NEMT. So it's still, in the eyes of some, a viable business startup, which I find very strange. And then in 2005, there's Safety Lou, which is this sweeping transportation bill passed by Congress. And so this is where the FTA gets involved. Prior to 2005, NEMT is just a program of Medicaid. But in 2005, Safety Lou, which was kind of administered by the Federal Transit Administration, starts requiring planning and coordination around NEMT. So now it becomes a program that's under both Medicaid and the FTA. So we'll fast forward to 2025. The federal guidance that we have today is virtually unchanged since 2005, and it's still very vague. So we have the Centers for Medicaid and Medicare Services, CMS, who tell us that states must assure necessary transportation for Medicaid beneficiaries. They also tell us that that service needs to be cost effective. Does that mean for the rider, the provider, or taxpayers who fund Medicaid? We don't really know. And then there's FTA, who provides funding to a lot of NEMT providers, and they also require these human service transportation plans as a condition for that funding. So we know that we need to be providing access to Medicaid services. It needs to be cost effective, and we need to be doing some kind of planning around it. But besides that, it's really up for interpretation. So this is another John Claudia slide. Where do planners fit in? So planners write those human service transportation plans that are required by FTA. And this was my job as a planner. And these plans are supposed to be accounting for all of the NEMT services in the region and identifying gaps in service. And if the MPO has equity as a directive, these plans are also supposed to be evaluating equity and access to NEMT. This is the Human Service Transportation Plan for the Austin metro area. This is their 2017 version, and then they need to be updated every 5 years. So here's 2022. Looks like they got a new graphic designer. I can speak from experience and say that writing these plans is incredibly challenging because remember when I mentioned that NEMT has like a private side and a public side? They don't talk to each other and they don't share their data with us. So like we don't really know the service hours of private NEMT providers. Sometimes we don't even know their phone numbers. We don't know when their websites change, when their terms of service change. And they don't share their ridership statistics with us. So data is very fragmented. There's a lack of integration across the NEMT models. So everybody who's providing this mode of transportation has a different idea of what it's supposed to look like, and there's no standard.
Can I ask a clarifying question?
Yes.
So the HSTP, it considers NEMT, but it's broader, right?
Yeah, ADA paratransit as well,
Okay.
any kind of specialized transportation.
Okay.
Yeah. Okay, so that brings me to my first premise, which is that ambiguous guidance leads to inconsistent service. And I want to explore that idea of inconsistent service a little more. And to do that, I want to show you what NEMT looks like on a more granular level. So it always starts with a rider, somebody who is on Medicaid and needs to get to a doctor's appointment, and they have no other means of transportation. And the rules of NEMT say that the rider can't really schedule the ride themselves. They have to call a coordinator. And that coordinator is kind of a middleman. And they have access to what's supposed to be an exhaustive list of all the NEMT providers in the rider's area, which includes Ubers, taxis, and more traditional transportation setups like this ADA transit van. And so the coordinator is going to make a match between the rider and the provider and schedule the ride on behalf of the rider. But what really makes it NEMT is the fact that Medicaid is going to reimburse the rider for the cost of the fare. And in many cases, FTA is providing funding to the providers. So just to reiterate, NEMT is really about the service coordination and reimbursement. It's not about the ride itself. Mm-hmm. And for this reason, NEMT rides take many forms. So an Uber can count as an NEMT ride if it's transporting a Medicaid recipient to a Medicaid doctor's appointment. Same with a taxi, and same with more typical transit. Okay, and so now to look at that idea of inconsistency in a different way, we're going to take a persona who we'll call passenger A, and we're going to put them in a bunch of different service contexts and see how things change. So these are passenger A's characteristics. They use a manual wheelchair. They need dialysis 3 times a week. They live alone, and they're reliant on Medicaid and NEMT to get to their dialysis appointments. And their goal is to arrive to dialysis on time, safely, and with dignity. So let's see what happens when we take that person and assign them to rides in 2 different states. So the first state is Colorado. And in this scenario, passenger A arrives on time, the driver assists them into and out of the van, and they have a wait time of less than 15 minutes. So they're going to be really satisfied with that. And the ride is going to be marked complete, which means the provider is reporting all of their ridership metrics to the federal government. So yeah, the ride is marked complete. Passenger made it from point A to point B. But in Illinois, in a different hypothetical scenario, the ride arrives 45 minutes late. The driver doesn't help the person with the wheelchair ramp, so they have difficulty getting onto the vehicle, and the passenger ends up missing their appointment. So they're not satisfied, but the ride is still marked complete because they made it to point A, from point A to point B. So the reporters don't care whether the passenger missed their appointment or whether the ride was uncomfortable. They just care if the ride was complete. So there are differences across counties too. Urban counties in urban counties, it's more common for providers to have apps that give riders real-time updates. And there also may be policies in place that ensure door-to-door service. So the person in the wheelchair is getting assisted from the moment they exit their home to the moment they enter the doors of the healthcare facility. So they're going to be satisfied with that, and that ride will be marked complete. But if they try a trip in a rural county, chances are they're not getting real-time updates. There's no app to tell them where the vehicle is. And maybe the driver drops them off at the curb. So they have to wheel themselves up to the door, which is uncomfortable and tiring. So they're unsatisfied, but again, the ride is complete. And then this is the last round of these. There can be inconsistencies among the same provider, but on different days. So on a Tuesday, there's a new driver on the shift. They arrived early, they're a great communicator, and they helped the passenger navigate an icy driveway. So the passenger's happy and the ride is complete. But on a Saturday, the driver is overbooked, which is not their fault. All of this is done by auto scheduling software that happens behind the scenes. But they're 1 hour late, and the driver also didn't secure the wheelchair. So the passenger is kind of rolling around in the back of the van. So they're not satisfied, but the ride is marked complete. Now, this kind of paints the picture that like there is one kind of ride that's best for everybody. Like maybe everybody needs an ADA accessible van, and everybody needs like those real-time updates, but that's actually not the case because people are different too. So we talked about passenger A, who is in a wheelchair, so they're always going to need an accessible vehicle with a lift. But there's passenger B, who is attending methadone treatment, and they prefer an unmarked vehicle to avoid stigma, because in some communities, being on Medicaid is stigmatized. So maybe an Uber is actually a better option for passenger B. And then passenger C is a single mom with 2 kids, so she's always going to need a car seat and a provider who's comfortable with family trips. And then passenger D is an older adult with memory loss, so they're always going to need door-to-door assistance and a familiar driver. So there are different kinds of rides, but also different kinds of people, and it's all about making a good match. So that brings me to the second premise, which is that inconsistent service leads to mismatched service. Okay, so there have been some scholarly explorations of this idea of mismatched NEMT. A lot of them have found that when NEMT rides are mismatched, money is wasted somewhere along the way. Either it's the rider's money, the provider's money, or taxpayer money. So it's an inefficient resource allocation. Scholars have also found that mismatched rides result in frustration and disempowerment, which just means a lack or a loss of trust in not only the transportation system, but also the healthcare system. But what I'm interested in is whether mismatched NEMT results in poor health outcomes and disparities for NEMT riders. So I have a third premise here, which is that delayed care leads to worse health outcomes. And we know this is true in general. These are 2 really widely cited like public health articles that have established this, but nobody's looked at whether this is true in the context of NEMT. But I think we have reason to believe that it is true because, again, there are all these points along the way where mismatched service can result in delayed care. So from the moment of booking a ride, you can have issues with eligibility or wait times. When the vehicle picks you up, maybe it's late or there's miscommunication. When you're getting into the vehicle, if you have a mobility limitation, that can pose a lot of issues if there's a mismatched ride. If an Uber sedan shows up, but you're trying to get on in your wheelchair. And then the in-transit experience can be uncomfortable, or maybe there are vehicle issues because of a lack of vehicle maintenance standards. And then arriving at the healthcare facility, again, can be especially difficult if you have a mobility limitation. So all of these things kind of add up and increase the likelihood of a delayed appointment or a missed appointment. And, a missed appointment, which results in delayed care. So you have to spend months waiting for your replacement appointment to come up. So yeah, that brings me to my research approach. Just to reiterate, it's fine. I'm just gonna move ahead. Okay, so research approach and study design. Okay, so what happens when NEMT service is mismatched? I have two hypotheses that maybe I can combine or I can narrow down to just one, but I have two for now. The first one is that NEMT riders experience worse health outcomes than other Medicaid beneficiaries and the general public because of mismatched service. And the other one is that NEMT riders who frequently experience mismatched service have worse health outcomes than NEMT riders who don't frequently experience mismatched service. But in order to test those, I think we need to define what is good service and what is mismatched service. So I have a research question for kind of my first phase of research, which is how can a typology of good and mismatched NEMT service relate to the health outcomes of NEMT riders? That brings me to my research trajectory. So I have 3 phases that I'm thinking about. The first phase is where we do that. We define what is good service and what is mismatched service. And I want to do that by asking practitioners and then eventually asking riders themselves and developing some kind of typology to help us define those 2 kinds of service. And then after that, I would like to assess the health impacts and compare the health outcomes between good and mismatched NEMT riders. And then finally, the big goal is to optimize service and make sure that this mismatch doesn't happen anymore. So that will involve recommendations for planners and also for providers. And then just a little more detail about phase 1 of the research plan. So I already designed a Qualtrics survey and an interview guide as part of the qualitative research class I'm taking now. So that is ready to be deployed, but I need to go through IRB exemption first. And then the dates are really tentative. I don't actually expect to get all this done so soon, but eventually I will need to collect the data and code it, and I'm seeking feedback on coding techniques. And then after that, I'll need to design the typology of good and mismatched NEMT, and I'm seeking feedback on that too. And I'd like to infuse some like planning theory into that, which I'll talk about in a minute. And then my sampling technique, since I'm going to be deploying surveys and doing interviews. So the National Center for Mobility Management and CMM published a report last year that tried to categorize the different models of NEMT. And they kind of narrowed it down to 5 categories, and then they placed each state into one of the 5 categories. So I was thinking for sampling, I would try to have an even representation of all 5 of these categories, but they're not supposed to mean anything to you guys. It's just a visual. Okay, and then phase 2 of the research is measuring the health outcomes and comparing the health outcomes between the groups. So I want to compare the relative differences in health outcomes between the entire population, Medicaid recipients, and then NEMT riders. And I've done a little bit of preliminary research on data sources. And then I would also control for age, gender, race, and ethnicity, socioeconomic status, and geographic location. So whether they're in using an urban service or a rural service. And then I've thought a little bit about how this would impact the field of planning. So I mentioned those human service transportation plans, or HSTPs. Currently, those just address like the service coverage areas of all the NEMT providers, the demographic needs of the region. So maybe there's a disproportionate or there's a high proportion of older adults in this region. So the plan might say we need to tailor our NEMT services to that demographic. They also outline funding streams and compliance. And in some cases, they're also evaluating equity and access to NEMT service. But I think that with this research, we could start incorporating rider surveys and feedback loops into the plans. We could also have funding priorities that are tied to the quality of the service instead of just whether the service like existed and whether the ride was completed or not. We can also start designing these plans with NEMT riders. And we can also have equity measures that are not just based on service, or that are based on service quality, not just access to the service. And then a little fact about NEMT, Uber is actually one of the largest NEMT providers. So they should be paying attention to this kind of research, I think. And I know that Uber Health, at least in the past, has funded research on NEMT, so that could be a potential funding source. But I feel like this research would apply pressure on TNCs or transit network companies to improve their service and also be more transparent about their data and their service standards and share that with the public sector and also with researchers. And then this is kind of tentative, but I mentioned wanting to have a theoretical orientation incorporated with the typology that I want to make. So the typology would kind of be based on the idea that everyone deserves access to healthcare, transportation, and not just access, but good service. So paying attention to that quality aspect too. I think that NEMT is kind of an interesting place to look at systemic failures in both the transportation and the healthcare sectors. So it's a cool combination. And then it's also a site where broader power dynamics play out. There are people with disabilities, people with low incomes, people of color, older adults, younger adults, all kinds of intersecting identities on NEMT. And I think it'd be interesting to explore that more. So then just a little bit about outreach and engagement. I'm trying to get involved with this group called Students for a National Health Program, which is just a group of students, mostly medical students, who are in favor of like socialized medicine in the US. And so I hope to get in conversation with physicians and other healthcare professionals and learn about medical transportation from their perspective. And then just some future considerations. We had Dr. Oz sworn in recently as the new leader of the Centers for Medicaid and Medicare Services. And he's said before that he wants to fully privatize Medicaid and Medicare. So that would have huge implications for this. And then kind of in line with your work, there are a lot of volunteer transport networks and community organizations that effectively they provide medical transportation, but it's not like official NEMT, but they are still filling a gap in the medical transportation landscape. So it would be interesting to look at that too. And that's all I have.
Mhm.
Yeah. Any questions? Any thoughts? I have some questions too. That helps.
I have a question. Actually, that's the first question you mentioned is the one I was wondering to ask you.
Mhm.
So I wonder how you will, what kind of categories you will ask people as how they satisfy to the service.
Yeah, so the questions I have in the interview or in the survey so far, they just ask like, what do you see as the biggest challenge in providing good NEMT service? Like, what are the funding barriers that exist? They're all kind of general questions, but I'm hoping that in the process of doing these interviews and surveys, I can narrow down key themes and find like maybe a central problem that everybody experiences across the entire country. But yeah, like the questions are pretty general.
A follow-up for the questions, the ones for the NEMT riders, is that gonna be more qualitative? Like, what does a quality ride or good ride look like to you? Like something like that, so you could pull out, some aspects of what they define good to be.
Yeah, that's what I'm thinking. I haven't put together like a survey or interview guide for the writers yet, just the providers. But I do want it to be open-ended and I just want to see what comes up and what they say and try not to force people into saying something. Yeah.
Have you mentioned the coding part that you were looking for feedback, like coding?
Oh, yeah.
Yeah, and you were thinking about like using any specific, I don't know, software, or because I'm also working on my coding now. I
Yeah.
wanted to hear something from you, like what are you thinking?
Well, in my qualitative methods class, we're using Atlas TI, which is not provided for UT students for free, unfortunately, but I mean, so I'm getting used to that software, so I would probably just like buy I think it's a monthly subscription and use that, and it's working well. And then I've heard of like a grounded theory coding technique. We've talked about it a little bit in my qualitative methods class. So that would probably be, that's what I would default to if I don't get any other ideas.
So you will be basically coding the interviews.
Yes. Yes.
Did you think about talking to Pablo from last semester about the coding aspects of it?
No, but that's a good idea.
That's it.
Yeah, for sure. Yeah, I'm good.
So this NEMT, only the Medicaid, who are in Medicaid, they can also only get access to this service. The Medicare people don't get it.
Yeah, so I think for Medicare, it's maybe called something else. But yeah, like if you're on Medicaid or Medicare, transportation to your appointments is covered if you can prove that you don't have any other transportation options. And again, it's about the reimbursement, not the mode necessarily. So like you can take an Uber ride, and as long as you're on Medicaid or Medicare and you prove that that was the only way you could have made it to your appointment, they will reimburse you for the cost of the ride.
How can people actually justify that? Like, I had only this Uber for my medical trip. Because I don't have any car. Like,
yeah, I don't actually know what the paperwork looks like to prove that, but I'm assuming you just have to check boxes and say like, I don't have any family members within 20 miles who are able to pick me up at 8 a.m. on Tuesdays for whatever. And I don't have a car or I can't drive. And you just check boxes and prove your situation that way.
in one slide, you showed like the like someone need to call training the coordinator.
Yeah.
Like, and it can be a business startup.
Yes.
Company like who are providing these coordinator services, right?
Yes.
And it's still the same in 2025, or it was like before?
Yeah, it's actually becoming more that way in 2025. So it really depends on the states, but I know in Colorado, there's like an offshore call center.
Mhm.
So people in Colorado are trying to get rides and they're talking to people who are not familiar with their local situation at all, not familiar with the providers there. And so the default is just Uber because everybody knows about Uber.
Mhm.
And the coordinators are not asking people, do you need an ADA accessible vehicle? Or do you have any other needs that we should know about? They're just defaulting to Uber.
So like I'm just wondering like how Cap Metro's on-demand ride services are like why they're not providing this NEMT service, like why they're different, like
So Cap Metro Access, like the short buses, they
Yeah.
do provide NEMT trips.
okay.
Again, it's not about the mode, it's about the reimbursement, so. Yeah, they provide NEMT trips, as far as I know.
Oh,
There's some questions.
Mimi, sorry, did I interrupt something?
I'm gonna get to the questions on Zoom, so go ahead.
Yeah, I was just so I will great presentation. Thank you for the invite. You asked about I think more input into your interview. So I put in the chat a book that I am using. You might know it. It's from Brown and Clark. And it's more actually related to health, public health. They do a lot of research in public health
Okay.
using qualitative thematics. So you might want to use that. It's super cool.
So it's the framework, you said?
Yes, I would say a framework and also practical advice, actually.
Okay, cool. Yeah, I didn't really catch the name, but I'm sure I can just follow up with you about
Yes,
that.
definitely. And it's in the chat.
In the chart? Wait,
In the chat.
Oh, sorry, okay.
Okay. And then for the third question, where and how to incorporate theoretical orientation, what do you mean exactly by that? Do you mean in your paper, in your presentation, or in what are you thinking with this question?
I guess I'm sort of thinking about the typology of good and mismatched service. Although maybe I would just want to rely on what people tell me and not infuse any like scholarly frameworks at all. So maybe on second thought, this would just sort of be for like framing the paper. But yeah, initially I was thinking that I would have some kind of theoretical framework for the typology, and then I would also supplement that with what the providers and writers are telling me.
Sure. So maybe that's a kind of I heard you a lot of saying that you will be relying on the interviewees. So that might be also a skill that you want to develop. I mean, there are many books around qualitative interviews, but you will have to make sure that you listen carefully and you listen a lot. You maybe use a lot of prompts, and yeah, so I think that's like a skill that you will have to develop throughout your interviews.
Yeah, and I think it's good that I'm starting with interviewing providers, because I don't think I'm prepared at this point to jump into talking with writers, and I don't have the training yet to do that. So just talking with professionals first in a professional capacity will be a good start.
Sure, and you can always try like start with students, just make that up. So
Yeah.
usually for the guides, the interview guides, we are asked to practice that with a student or someone else, maybe a family member, or whether to make sure that it flows correctly and it's like people understand what you want, your questions and these type of things. You don't have to be even very fancy at all.
Okay, yeah, that's helpful. Thank you, Sylvie. And then I see Amanda has her hand raised.
Hey, yeah. This is really, really exciting to see like how all of your ideas have come together into this like, yeah, early steps for a proposal. I wanted to ask, because I know it's just like some things that we have talked about in the past, and I imagine you're addressing it, but when you were talking about like you're interested in creating a typology for understanding quality and how users, writers kind of experience quality and how the providers are attempting to provide that quality. And it's a lot of like the scenarios that you did with the types of rides and then the writers all still kind of seem like the point A to point B, and then like, is it marked complete? And one thing we've talked about is just the scheduling of it and how much time goes into scheduling it, how many days in advance they have to schedule it, if they get told they can't schedule it when they try, and how many rides are not even getting scheduled, thus could never even be marked complete or incomplete because they're not even getting scheduled. And then when riders know that drivers can be late, so then they're telling them their appointment's an hour earlier just for that buffer, but then they're arriving somewhere an hour earlier, and that, you know, kills a bunch of time. So I was wondering, like, outside of the point A to point B ride, I imagine you are, but like, you're also part of quality is also just from the very first phone call to schedule it.
Yeah, that's a really good point. So the public agencies that provide NEMT are supposed to be tracking their trip denial data, which is data about when somebody calls and requests a ride, but for scheduling reasons, there's not a vehicle or a driver or both that are able to pick them up at the time they requested, so that their ride gets denied and they have to find another option. And usually they go to Uber after that, because under Medicaid, they have to receive transportation, but it can be public or private. Anyway, so Amanda, yes, I want to ask the public providers for their trip denial data, but that is something I don't know how to get from the private providers, and I imagine they don't really have trip denials, especially for Uber, because there are always more vehicles and more drivers. But yeah, that's a good thing to think about, is like all the rides that never even happened in the first place because of some kind of shortage or other type of mismatch.
And
Awesome, yeah. And then I wanted to say too, I put in the chat, I think it was maybe your theoretical orientation slide, you know, where I mentioned like mobility justice, but I had just read this article recently where they bring in like structuration theory, Gideon structuration theory. So I just popped that in the link. I don't know how relevant it is to you, but considering power dynamics. So yeah, just a random reference that I thought of.
Awesome, thank you, Amanda.
And Mimi, to follow up on that, I have like a general question. I know you mentioned that the person from the new leader at the CMS wanted to work on this issue or kind of similar. I think so, yeah. To fully privatize. Okay. So what does it exactly mean? Do you know, will that affect this service? Since we are talking about defunding Medicaid or these type of things, how do you see that affecting your work?
So I don't know about defunding Medicaid and Medicare, but I've heard that Dr. Oz wants to privatize it fully. I don't know what that would look like. I don't really know if it would remove access to public NEMT providers or something. I don't know. I don't think anybody knows, honestly, but it's just something I want to be tracking and maybe asking my interviewees and survey respondents about like whether they've heard anything through the grapevine about what's going to happen with Medicaid in the next 4 years.
That's a good point, yeah.
Yeah, so the budget resolution that Congress is considering is contemplating $800 billion or so of cuts to Medicaid.
Okay.
So who knows where that will go, but something to be aware of. Couple other things that I thought of as you were talking. First, it's really good.
Awesome, thank you.
Yeah, so And it seems like you have that one slide with the kind of 3 different phases maybe, and it seems like
Yeah.
that would be a good like 3-paper model potentially for a dissertation.
Yeah.
Like that one. I think
Yes.
those could easily be 3 standalone pieces that fit together to make a dissertation. So that's great. One thought that I had though, just in terms of like the substantive research, is that you're focusing on these Medicaid beneficiaries who use NEMT.
Mhm.
I imagine it seems like the kind of process for acquiring NEMT rides is kind of like Byzantine and annoying. And so I imagine that many folks who potentially could benefit from these rides are like foregoing travel or relying on friends and family or trying to get a car.
Yeah.
Or just kind of like using the bus or other modes of public transit as available. And those folks are still experiencing different types of transportation disadvantage or constraints on their travel. You wouldn't see them if you're
Mhm.
focusing just on NEMT users, but it seems like their stories, and maybe sometimes they use NEMT, but sometimes they don't.
Yeah.
So you wouldn't necessarily capture them. So I wonder if maybe you want to just like zoom out a little bit and think about transportation challenges for Medicaid beneficiaries
Okay.
in general, and then NEMT is one piece.
Yeah.
But there's a whole set of other challenges that people experience, so something to think about.
Yeah.
And then in the terms of the research design, you kind of glossed over this, I wonder if you thought about it, but just like how will you access Medicaid beneficiaries in terms of the sampling strategy?
Yeah.
When you need to collect data from them? Is that presumably other people have done it and it's possible, but
Yeah.
it might vary state by state? How will you do that?
Yeah, I haven't thought about it very deeply yet. I do know there's something called the National Medicaid Database. I don't really know what that is yet, but I just saw that and was like, oh, that sounds good, so I'll put that down.
Okay.
I'll look into that. I know that in some cases you can get access to like electronic health records, EHRs. And then if I could trace those back to whether the person was a Medicaid beneficiary, and then even more, even less likely whether they used NEMT to access their
Yeah.
appointment, that would be a way to evaluate health outcomes.
Are there, in terms of how Medicaid benefits are delivered, are there specific, I have no idea about this. Are there specific places where Medicaid beneficiaries can go to get services, or could they just go to any hospital and then the hospital bills the state? So in that case, if there were specific facilities, then you could potentially recruit there.
Yeah, I think it's a hodgepodge, like,
Okay.
it depends on the state, but most people receive Medicaid through like private insurers these days, so they may have like Blue Cross Blue Shield or Aetna, but then they just get, like, it's paid for through Medicaid, but the actual insurance provider is a private
private
insurer, yeah.
Okay.
So it's not really a public health program, it's just a public health reimbursement for private health insurance and private health care.
Interesting, okay.
In most cases, I know that there are like public health facilities in some counties. I know Austin has a network of like taxpayer funded clinics.
Costa Regional.
Yeah, but I think that's for people who don't even have Medicaid. You know, because if you have Medicaid, you're gonna go to whatever hospital is covered by your private insurer, and then
Yeah.
Medicaid's just paying for it.
Yeah, I wonder if there's some way to identify places where low-income people tend to go. And so those folks will be more likely to have Medicaid, and then you could recruit there, and it's part of your like inclusion criteria. You can just say like, are you a Medicaid beneficiary?
Yeah, or it could just go on board like the public NEMT providers'
Yeah.
vehicles and
Yeah, potentially.
meet people. kind of
Yeah, that's
on
true.
transportation.
That'll be a tough part
Yeah,
of the research design for sure.
yeah,
And then the other thing I was gonna say, so I really like thinking about the link to health,
mhm,
the way that you framed it. So the project that we're working on together, a lot of the feedback that I'm getting is like, well, what is the actual like health endpoint? That you're interested in, and it would probably be good for you to think a little bit more specifically about that. Like, for example, like, do you want to focus specifically on dialysis rides? Like maybe that's a health endpoint that you can kind of focus on, or is it more about like mental health or something?
okay,
Especially like something like this, I think would be really good for NIH funding. but they want to see a specific link between whatever mechanism you're studying, inconsistent transportation or
Mhm.
variations in transportation quality, and like a specific health outcome, not
Okay.
just like all-cause mortality or
Okay,
all like general morbidity.
that's good to
They
know.
want something specific. So yeah, thinking a bit more about that, I think would probably be good.
Okay,
But yeah, in general, this looks really promising.
cool.
Yeah.
I don't see any more questions on Zoom. So, oh wait, there's something in the chat. Okay, that's just the resources they're sending. Thank you
Oh,
guys for
sure.
sending those.
Yeah, that's good.
Okay, I'm gonna shut it down now, so. Bye.
Thanks, internet people.
Yeah, thank you. We'll talk soon. Appreciate it. Bye.